Following program contains mature subject matter. Viewer discretion is advised.
She took a big uppercut right to my cheek.
When nurses are confronted head-on with violence.
I've seen a knife being pulled out on a nurse.
Then,
I couldn't really find a doctor that could figure out what was wrong with me.
how she solved this medical mystery.
I'm shocked this was misdiagnosed for so long. Plus, homeless have a life expectancy 25 years shorter than the average population.
The doctor taking his practice to the streets. That's today.
Nurses are the front line of patient care and safety at our hospitals, but who is protecting our nurses when the workplace environment becomes violent?
The American Nurses Association reveals a shocking statistic. 1 in 4 nurses will experience verbal or physical violence in their career. The majority of these violent attacks occur in the ER. Nurses have been punched, scratched, and even assaulted with weapons. In one survey, nearly 20% of nurses said they were afraid to report their attacks in fear of losing their job. Since the start of the #MeToo movement, a growing number of nurses are starting to speak out about this very disturbing epidemic. Now the question is, what else needs to be done to ensure the safety of nurses in the workplace?
Our first guest today is a nurse who experienced this violence firsthand. Please welcome Randy, who joins us via Skype. And Randy, thank you for being here. First question is, how long have you been a nurse now?
I've been a nurse for about 9.5 years. Always known I wanted to be a nurse from the time I was a little kid. I knew my calling was to be a caretaker. And the 9.5 years that I've been a nurse, I've been in emergency medicine.
Well, I personally thank you very much for the work that you do.
Thank you.
Unequivocally can say that emergency departments do not run without the work that you do. And I'm sorry that you did experience this type of workplace violence. Can you explain what happened when you were attacked?
Yeah, I wish I could say it's the first time. I've been attacked many times in my 9 years, but it was never this bad. It was a typical day. Show up to work at 6 a.m., 6:30 in the morning. I walk into a patient's room. She needed medical clearance in order to go on to the psychiatric facility. I turned my back for maybe just a second. She was compliant, lying in bed. When I turned back to draw her labs, she took a big uppercut right to my cheek. And it took myself and another nurse a few minutes holding her down in the bed until security arrived.
And what is security like at your hospital?
We had one security officer in our hospital that day stationed in our ER lobby. So that took probably a couple minutes. It felt like 5 minutes while I'm struggling with this girl, holding her down in the bed, waiting for help to arrive. But he had to respond from the ER lobby into the main ER proper.
And Randy, do you have any sort of special protocol when you're dealing with a mental health patient?
There is policies and procedures in place on how to deal with mental health patients, substance abuse patients. The problem is lack of staffing. That day that I was punched, we were running 3 nurses short already. I stayed on shift for 7 hours after I was punched. The main reason was because I knew that if I left, if I went home, I was leaving my team now 4 nurses short.
And I might just add to that, Dr. Orden, there are times in the ER where over half the patients have mental health issues or are on a substance that may lead to unexpected violence. And this is a problem that's growing worse and worse. And there are a multitude of reasons that we're going to continue to uncover. Joining us now to weigh in studio is the founder of Nurses Against Violence Unite Incorporated, Dr. Sandy Risoldi. Sandy, you are on the front lines of this as well, and unfortunately, in your experience, Randy's story and in my own is not uncommon. Can you talk about how familiar these types of stories are to you?
It is very common. It is absolutely common. I see it all the time. I see nurses getting hit for no reason. I see them getting yelled at, spit on, their hair pulled. I see people getting punched, kicked, and even I've seen a knife being pulled out on a nurse.
So, Dr. Risoldi, it feels like the incidence of these types of attacks have gone up, but it also feels like because of legislative changes, nurses are in a particularly vulnerable position. I know Dr. Stork mentioned it in the opening that many nurses don't report this because they're afraid of retribution. Mm-hmm. What defenses do healthcare workers now have if they are assaulted in the ER where they don't have to worry about reporting to their employers?
Well, there is nothing. I am from Florida. We're really just out there with nothing. So the ER, they more times than not, and I'm sure Randy will agree, they get trained in like some sort of like techniques to help protect them. Now, if you by chance like go up an inch, the facility has you on camera and they dismiss you, and that's your retaliation. Good luck. We're not going to cover you because you look like you were hitting the patient, even though you're blocking.
And this is a big problem because of the evolution. And here's the beauty and the curse is that more and more patient protections are in place, which is good. But the reality is that you can be in the ER and be physically attacked. And if you try to protect yourself, there are really no protections for you. There are a lot of protections in place for the patient. And the reality is times have changed. From when I first started practicing, if someone was attempting to beat up anyone in the ER, it was all hands on deck to help protect everyone. But nowadays, there is a hesitancy, and unfortunately, if there's only one security officer and they're 3 floors away, everyone's a little bit afraid in terms of what to do.
To the reality of that situation, because California passed a law last year that covers workplace violence for healthcare workers. Therefore, we have to be compliant in the sense that they have to provide us self-defense training. So learning self-defense in a 4-hour class once a year, and then going into the reality of a patient's room when they're swinging at you are 2 completely different things. And a 4-hour class of self-defense isn't going to protect us.
And also, if you self-defend in the wrong way, it's on camera and you know, it's, wait a minute, was that self-defense or was that assault?
And a lot of these patients who probably should be restrained, they're not being restrained because people are reluctant of the medical legal issues that are going to come from that. So it's
So
a
can
bad
we
situation.
address,
Yes.
let's address that and try to talk some solutions here, because that's why we're having this conversation.
Yes, so when a patient is admitted, they get a survey. And when they get the survey, it's whether the facility is going to get credited, going to get paid. So what happens is if they get bad, the HCAPS, when that was applied, now the organization looks on the nurses' aides and the nurses and puts pressure on them, because if they're not getting reimbursement, so therefore the easiest way to get back and make sure that hopefully this gets corrected is going and putting full force on the nurses' aides and the nurses. Therefore, they're left defenseless, and no matter how much that they try to report things that are happening, they're retaliated against for reporting because there's literally a failed reporting system. So solutions would be something that, like anonymous reporting, so that 1309 is talking about the retaliation of organizations. So, and what the solutions, what we're proposing with Nurses Against Violence to add on to that would be to implement anonymous reporting that OSHA actually adheres to, like with the healthcare segment, to add to the OSHA, the current OSHA that we have, because they're not being addressed the way that they should be. One of the other solutions that I had was to talk back to the 1309 was that that there would be felonies for people that are hitting nursing staff, like for the nurses' assistants and the nurses, because it needs to be spread across the board.
Well, and I think your point is so valid. No one should be able to walk into a hospital, a doctor's clinic, or any clinic for that matter, and quite frankly, beat up a nurse and have there be no repercussions. And I think that's kind of the climate we live in right now. And protection is so important. Randy, I want to ask you, have you as a nursing staff come together and thought more about how you're going to combat this in your hospital?
Fortunately, I have the privilege of working with a really incredible chief nursing officer who has his own story, attacked in his past. And just 2 months ago, we met with the senator, and we're all on the same page. We all know that this can't be happening anymore, but getting us there is the next step. I kind of feel like we're in this paradigm shift right now. What 8 years ago we used to accept as everyday nursing behavior, oh, that patient just slapped you, that's part of the job. We're now moving into a zero tolerance policy, but getting everybody on board is kind of the tough place to that we're headed. And that's, I'm so happy that you guys are talking about this right now, because this is something that the healthcare field has been feeling for years. And we are moving forward, talking to our legislature and trying to all get on the same page, but it's not an overnight fix.
Well, thank you both for the really good work you're doing to raise awareness. Randy, thank you for sharing your story. I'm so sorry that happened to you and that it seems to be so commonplace. But hopefully some good will come out of it.
Change will come, and that's because the last thing we want to see is to lose our great healthcare professionals like yourself. And
that's my biggest fear as well.
The system
So
is
thank
going to
you
fall
so
apart.
much for having us on your
I would
show.
also like to see that the hospitals realize this and step up and increase security, because I think that's an important part of it as well.
It absolutely is, and we did reach out to the American Nurses Association. Their statement reads, the American Nurses Association condemns all instances of workplace violence that nurses face in every healthcare setting. ANA is working hard to address this through policy and efforts such as the #EndNurseAbuse campaign. You can find the full statement on our website, thedoctorstv.com. Sandy, keep up the great work. And Randy, thank you so much for sharing your story with us. We'll be right back.
Coming up,
I was misdiagnosed many times. I was told that I had degenerative disc disease. After that pregnancy is when things really started to get worse.
then
There's a legal checklist you go through before you formally fire a patient.
It feels like something else was going on, because in no world can I imagine a scenario where a good Samaritan says, you know what, I'll pick up their bill for them, and then you just kick them to the curb.
that's coming up.
Most types of post-pregnancy pains don't last long, but for our next guest, not only did her pain last years, it went misdiagnosed.
I was a triathlete for many years. I ran competitive 5Ks. I was a fitness competitor. When I had my first kid at age 24 is when I first started to notice the pain, and at the time, I really just thought it was my tailbone. I was misdiagnosed many times. I was told that I had degenerative disc disease. When I went through my second pregnancy, I was 35 years old, and I had twins, and they were 7 pounds each. After that pregnancy is when things really started to get worse.
So I probably went to 10 to 12 different physical therapists.
A lot of times I couldn't even bend over to brush my teeth. I would get steroid injections. I even had SI injections directly into my SI joint, and I had maxed out the number of injections that I could get. It was probably the last 15 years that I really struggled trying to find someone to really figure out what was going on with it.
My last physical therapist was able to pinpoint that it was coming from my SI joint, and it was kind of like an aha moment.
Everyone, please welcome Jamie to the show. Jamie, I'm sorry you went so long not getting the proper diagnosis and suffering in pain. Ultimately, you got the correct diagnosis. Can you talk a little bit about that and then what you did next?
Once I did finally figure out that it was my SI joint, I started doing my own research and trying to figure out, what I could do about it, because, I couldn't really find a doctor that could figure out what was wrong with me. So I took it upon myself to really use Google and go and do my own research and find a procedure that was going to help me.
Well, we're also joined today by orthopedic spine surgeon Dr. Michael Mohimi. And let's talk just briefly, if we could, about how common women might end up in a position like Jamie, misdiagnosed or wrong diagnosis or delayed diagnosis for something like this.
Well, we think somewhere around 5% of all pregnant women probably have some type of sacroiliac pain or dysfunction. But more importantly, is like the general population as a whole has lower back pain. About 80% of people have lower back pain. And there's about 30 million people living with chronic lower back pain. Of that 30 million, maybe 10 to 30% have SI joint issues. Until doctors and patients kind of really recognize SI joint as an issue, it's going to continue to grow.
And I'm just curious about how you helped her. Tell us about what you did.
Yeah, well, she's definitely failed all conservative treatments. We want people to do everything besides surgery. And so if you fail conservative treatment, the surgical option you can do is a minimally invasive surgery, something called a minimally invasive sacroiliac fusion. And I use this iFuse system. And basically, just like a joint anywhere in the body, the hip or the knee, you have two bones that normally move. You want to stop them from moving, and then it won't hurt. So you can drill across the joint and create a path, and then place a triangular implant across the joint. That triangle stops the joint from moving, and then if you don't move, it doesn't rub, no inflammation, no pain.
But can you do this if you're planning to get pregnant again? Because once you perform that fusion, wouldn't that be difficult with the subsequent pregnancy?
Yeah, in general, that's kind of a contraindication for doing the procedure, is because you will lose the ability to kind of get the pelvis to expand. So you could have to have C-sections if you have that procedure, especially bilateral, both sides.
All right, Jamie, how are you feeling?
I feel great. I mean, it's like a new lease on life. I mean, as soon as I got the surgery, it was super easy. I was in and out of the hospital really quick. I got home, spent 6 weeks on crutches, but I could immediately sit up, like even in the bed, which I couldn't do before. I couldn't sit in a chair for, a couple of years. And I mean, now I'm, boxing, I'm lifting, I'm running, I'm spinning, I'm yoga, I'm coaching my daughter's soccer team, which it never would have dreamed I could be able to do.
Good for you.
So,
That's a lot.
so Doc, no limitations after doing the fusion. She can go back to everything she was doing, and it sounds like even more.
Yeah, correct. I mean, right immediately post-op, we try to restrict their weight bearing a little bit, give the bones a chance to heal. After that, once the bone is grown, yeah, sky's the limit.
And I would love for our control room, if you could just pull up that image again of the sacroiliac joint. And I want everyone at home just to look at this area, because there are a lot of people out there who don't understand. It's in an area that's slightly different than your traditional low back pain, and yet a lot of people aren't familiar with it. And if you notice that your pain is kind of right where that sacrum and ilium meet, you may have to even be with your doctor and say, hey, this is different than anything I've had before, and really try to get the correct diagnosis, because if they just keep treating you for back strain, you're not going to get the proper treatment. Yeah. So sacroiliitis, that is a term we should all be familiar with. We're just very happy, Jamie, that you have the fix that you needed.
Yeah. And that you were your own advocate and you were able to figure this out. So well done.
And sorry it took that long. Dr. Marini, thank you for your diligent care. We'll be right back.
Coming up.
There's a legal checklist you go through before you formally fire a patient.
It feels like something else was going on, because in no world can I imagine a scenario where a good Samaritan says, you know what, I'll pick up their bill for them, and then you just kick them to the curb.
Then,
when I decided to go to medical school, this is very much what I envisioned. I have several patients that I had a really close relationship with and was able to see them make positive changes in their lives.
That's coming up.
A Tennessee woman says she was dumped by her doctor after she tried paying another patient's medical bill when she overheard him tell the front desk that he couldn't afford it. The woman later received a letter from the doctor's office saying her physician-patient relationship was terminated due to significant philosophical differences in views. Joining us to get to the bottom of this is attorney Tiffany Fetter. At surface level, it sounds like philanthropy and maybe gone awry. Maybe there's more to this story, but legally, I'm assuming if it were as simple as that, you probably couldn't fire a patient from your clinic just for paying another patient's bill unless there was some HIPAA violation involving the person paying the bill. Is that fair to say legally?
Absolutely. And also the patient, from what I understood from the story, the patient overhears, the patient's trying to step up, do the right thing. The doctor's supposed to promote health. And if somebody doesn't have access to health for a financial reason and somebody wants to jump in and pay it, that's great. They weren't asking for the patient's name or anything. The patient actually found out through Facebook. And I think in that kind of a situation, it's unfortunate that this is what it came down to and the doctor dumped the patient. But, at the end of the day, where do you draw the line? A doctor doesn't have to treat a patient they're uncomfortable with for whatever philosophical differences. This is absolutely extreme. It's disheartening at best, but a doctor can absolutely not treat a patient for whatever differences.
It makes me wonder if something else was going on here, because I have to tell you that it feels like something else was going on, because in no world can I imagine a scenario where a good Samaritan says, you know what, I'll pick up their bill for them, and then you just kick them to the curb? It has to be some other explanation.
I completely agree that there's clearly something else at play here. And the problem in a lot of these social media posting hearsay about what's actually happened is you're only getting one side of the story. And physicians can't respond because of federal privacy regulation. So this patient posts online that this doctor fired me for being a philanthropist and I was trying to be a good Samaritan. I'll speak as a practicing physician. I don't think any of us would fire someone who was with good intent doing that. We don't do that lightly. And there's actually a tremendous amount of legal responsibility that goes into firing a patient. You have to provide them emergency care. You have to notify them. You have to provide alternative care. I mean, there's a legal checklist you go through before you formally fire a patient. And personally, I mean, I'm in private practice. I very rarely fire a patient, but I'll tell you a recent incident that happened to me in my practice was a patient came in to me for a cosmetic procedure, was consented, was quoted, paid for his procedure, left the practice, and then decided to submit the procedure, which was very clearly all documented cosmetic, to his insurance, and said that I had tried to charge him for a covered benefit, which resulted in the insurance sending me a letter trying to say that I had done something wrong. I submitted all the documentation to them and said, no, he's committed fraud. This was absolutely cosmetic. It was very clear. And so I turned around, I sent him a letter, and I said, respectfully, what you did was fraudulent. You're very aware of it. You're dismissed from this practice. The next thing I know, he went online and he said about me and my practice that I had charged him for a procedure that was covered by insurance, that I'm the one who did something wrong. And I was livid, and I was so defenseless. I can't respond.
You can't respond.
Because if I say anything about it back,
Right.
that, no, you're actually the person completely in the wrong here, and I feel attacked, and I feel vulnerable, and I tried to do the right thing, and you cheated the system, then basically he could sue me for a privacy violation. So this happens all the time. I think when you hear something on social media, you have to, or a review site, remember that there are two sides to that story, and you don't necessarily know the other end, what happened to this doctor. Maybe the lady said something very offensive to him about the aspect that he was trying to collect charges for his services. You know, I just don't know. But I'll tell you, it's happened to me personally, and I did everything in good conscience. So I always feel like there's a little more to it.
Let me ask you this. This is going to go in a direction I wasn't expecting, but today for some reason feels like the show of, okay, what are the providers' rights? In segment 1, we talked about nurses being violently attacked, feeling like they have no recourse, talking about, okay, how do we empower nurses that they can have some recourse? Well, what is the legal recourse in a situation where, let's just say, not all patients are good patients, right? There are some outliers out there where maybe they will call you a fraud and say all these things, but you can't say anything back. Is there any potential negative consequence for just making false claims towards a practitioner?
Well, you're talking about defamation and you're talking about libel. And whenever you're talking about somebody's business and how they conduct business, it's one of the libel per se categories. So in a very roundabout way, absolutely, there's recourse. But remember that it's all weighed against the freedom of speech. We have a constitutional right. They have a right to think that you're a fraud, and they have a right to think whatever they want about you. It's protected speech. So that's, again, a very fine line. And where do we draw it? And unfortunately, you can't respond to your patients. I can't respond to the disgruntled client. Privacy and privilege are huge, huge things, and it's protected speech.
Well, I know that what my attorney told me in this particular situation, because I'll tell you, I was furious because it was such a gross misrepresentation, is that apparently, like you said, these reviews are protected. It's very, very difficult because he's stating his opinion and he has the right to his free speech, even if it's completely false, because there's no way other than suing him privately and producing the facts of the case, which again could expose me to privacy violations.
Right.
It's
a
like
lose-lose
this
situation.
Byzantine, crazy lose-lose situation. So doctors just take it, and we have it.
Just like lawyers, we have to take it
Well,
too.
and the lesson is, I think, for everyone is when you hear a headline, before you go to judgment or make a judgment, you always have to dig a little bit deeper, because a lot of the things even topics we talk about on the show, you read the story, you read the headline, it's like, oh my gosh, this is so egregious. But then maybe you peel back the layers of that onion, you're like, wait a minute, this is a little trickier. What are the elements here?
And I think faux news, my friend.
Well, but we live in a day and time where it's headline driven, it's social media post driven, and you'll hear something and you'll think that is egregious. And the only reason I bring that up is sometimes, quite frankly, I hate to say this, but the best providers of healthcare out there may have a bad review or 2 or 10 online, and there's nothing they can do about it. Maybe the best doctor in town, so maybe they are recommended to you by 30 of your best friends, but then you go online and you see, well, wait a minute, they have 5 one-star reviews.
Why is that? Because
maybe it's because they're...
they said no.
Maybe.
And they said, you don't need that. They came in seeking something, had something on their mind, I need this medication or this treatment, and didn't get it, and that makes you a bad doctor.
But the one thing I cannot argue with, if this story we started with is true, hey, if you as a patient, you individual, paid someone else's bill because you overheard them saying they couldn't afford it,
good for you.
Kudos to you. That is,
Yes.
that is what being a good Samaritan is all about. Tiffany, thanks so much for weighing in. Let's take a quick break.
Coming up,
When I decided to go to medical school, this is very much what I envisioned. I have several patients that I had a really close relationship with and was able to see them make positive changes in their lives.
then
One way to make sure your child is eating healthier is to invite them to cook with you.
I was going to start cutting red bell pepper, and I'm going to work on some cucumber.
that's coming up.
Our next guest is a doctor who doesn't just make house calls, he takes his practice directly to his patients on the street.
Now, this Reading doctor's office is under bridges, in the brush, and away from most of the population.
I'm a little bit worried, not only because you have this big abscess, but you've got cellulitis around your eye.
Dr. Kyle Patton practices street medicine. He goes to where his patients live, where he was diagnosing and treating medical conditions out of his backpack. And he would have it no other way.
This was very much, when I decided to go to medical school, this is very much what I envisioned. A big part of my job in going out is really to build trust and help our patients to see that we really have something to offer them.
Some might call him an enabler, and he is, he says, enabling his unsheltered homeless patients to get out of the camps and into homes and healthier lives.
I have, several patients that, I had a really close relationship with and was able to see them, really make positive changes in their lives as they sort of got into housing and, got into a more stable living environment.
Dr. Kyle Patton joins us via Skype, and I just want to continue clapping. I applaud you, Dr. Patton.
Thank you.
Really
Very nice.
remarkable. We were singing your praises before the show started. We love what you're doing. And if you term it street medicine, can I ask you when you started practicing street medicine?
Pretty much I've been doing this for the last 10 years. I basically started this before I got into medicine. I had just graduated from college. I was looking for a job, and I found this listing online for a homeless outreach worker in Salt Lake City, where I'm from. Subsequently took the job, started doing that, and really that was where I was exposed to working with our unsheltered homeless populations, and truly just fell in love with this kind of work, and it really kind of took off from there.
How often do you get out to see this population?
Right now I'm going 2 days a week, and then the rest of the time I'm in clinic, seeing my clinic patients, and then I also staff one of our mobile outreach vans. I've tried to make my medical practice as mobile and flexible as the patients that I'm treating. And so, we've got a truck that has, good four-wheel drive, and I carry a bag that has all sorts of supplies, basic surgical supplies for doing procedures, wound care supplies, lots of medications. And really what we found is, as we've gone out on the street, we've found that a lot of the patients that we're seeing have either never been seen in our clinic or haven't been seen in quite some time. So it's really been good for us to reconnect with those patients, because a lot of them have really significant medical issues, and sometimes their medical needs are more than what I can offer, and we have to either send them to the hospital. But I've really been surprised just how much I can do right there.
And I couldn't believe the statistic that homeless individuals have a life expectancy that is 25 years shorter than the average population. And I have to believe the work that you're doing is improving that statistic. When you're going out there, I just want to understand the logistics, because obviously it's really difficult to practice medicine in a clinic or in a hospital, but you're actually going out to encampments. Do you go alone? Do you go with other individuals from your clinic? And how do you go about assessing situations, whether or not they're appropriate, potentially dangerous?
I don't go out alone. I go out with a team. I go out with, the team consists of myself, a medical assistant, a case manager from the clinic. And the team approach is really important, because as I'm providing medical care for our folks on the street, the other team members are building trust with them and really trying to address their complex social needs, really with the ultimate goal of trying to get them connected to resources and eventually exit homelessness.
Dr. Kyle, I mean, kudos to you. What a
Yeah.
project. So commendable. How do you get funding? Do you have something in place to raise funds and receive donations if somebody wants to help your project?
It's kind of a mixture of, we do some, billing for our encounters, and then, a lot of grants support the work that we do. And then also personal donations. People can donate on our website, and that goes directly to funding supplies and medications and, our staff, and really keeps the lights on and keeps the work that we do going.
Well, there may be a few things wrong with medicine in this country, but Dr. Cal, you are not one of them. Keep up the great work.
Thank
We're going to
you
have a
so
link on our
much for your
website
work.
if you want to support the work that Dr. Patton is doing. Keep up the great work, and thanks so much for joining us.
Thank you.
Yeah, thank you for having me.
We'll be right back. Coming up, one way to make sure your child is eating healthier is to invite them to cook with you.
I was going to start cutting red bell pepper, and I'm going to work on some cucumber.
Then you can get a pillow like this, put this side up, and you may end up with... That's coming up. A new study published by JAMA Pediatrics found that nearly 1 in 5 adolescents in the U.S. are pre-diabetic. One way to make sure your child is eating healthier is to invite them to cook with you. Yeah. Please welcome Ben and Kaya from Daddy Daughter Cooking. Welcome. Good to have you
guys.
And, all right, thank you. Dad, I'm going to ask you this question first. What motivated you to start cooking with Kaya?
Oh, gosh. Years ago, when she was about 4, I was prepping for a class, and anyway, she comes in wearing its junior chef outfit that her grandmother had picked up, and wielding a spoon, and just very adamant about being a part of the cooking process. So I got her more and more involved with little tasks in the kitchen. And then once she became around 7, she's like, Daddy, I think we should just write a book.
Aw,
And
that's
so
so lovely.
we worked on that for a little while. And now in 2015, Daddy Daughter Cooking had begun. Right?
Yep, that's fantastic. Kaya, what do you enjoy most about cooking with your dad?
Well, I like that I'm able to actually know what I'm actually eating and not like buying stuff from a fast food restaurant or restaurants in general, not really knowing what goes into the food.
And I love that you do this together. We always promote that. So you brought some special foods for us to try today, starting with, what is this? This looks delicious.
It looks amazing.
So this is actually our peanut butter and jelly crepes. We make them with whole wheat flour, AP flour, which is all-purpose flour, a little bit of egg, some sugar, and Kaya generally whisks everything together. And then for parents, it's usually a good idea for them to kind of take the reins when it comes to any sort of heat, especially with the pan. So when we're swirling it around.
So Kaya, show me how you might put this together. And while you do that, I'm going to pass this over to my colleague, Dr. Butcher. So you start showing us how you do this. Is this peanut butter?
Yes.
Peanut butter and jelly.
Peanut butter and jelly. But what's beautiful about this is I also have raspberries, blueberries, blackberries, extra antioxidants. You're a true artiste, aren't you?
Yes. This is delicious too. It's kind of an update on a classic, right? This is something all kids can get behind, but it's also kind of a little bit more modern whole wheat crepe. It's delicious.
And we also do our own jams and jellies and preserves, which is another fun thing that anybody can do together.
So you make your own?
Yes.
And you know what's great about that is you can kind of control the sugar content. A lot of times you go get a jam and really all it is sugar flavored as a fruit.
Yeah, in ours we use coconut sugar instead of actual sugar, so it's a little bit less, I guess it's better for you, or less.
And I have to tell you,
hurt you less.
This is the best peanut butter and jelly thing I've ever had. So thank you.
It's really tasty. Aw.
And it's fun too. All right, what do we have next?
Okay, so the one thing that we also, with food and or meals or daily meal plans, we try to work, it's a full-on balance. So we try to balance our days with a breakfast, lunch, and a dinner, and maybe a little snack here and there. In this case, we started with the crepes, and we move into something a little bit lighter, but also has protein and various vegetables, lots of vegetables, actually. So this is our take on a Chinese chicken salad, and Kaya's gonna start cutting here on a red bell pepper, and I'm gonna work on some cucumber.
So, Kaya, I see that you're pretty comfortable with the knife there, but Ben, do you have any tips for teaching kids how to handle knives?
Absolutely. My recommendation would be to start with a plastic knife or a wooden knife. That way, once she feels, well, in her case, when she felt a little more comfortable with the knife, she's got her own knife set now, and so she works and plays around with them. But practice is the most important thing for anything in the kitchen.
Kaya, how old are you now?
I'm 13 years old.
So you're really comfortable. That's great.
Yeah.
Fantastic. When did you transition her from the plastic knives or the real knives to this?
She got her first knife at around 8, and so she's been playing around with that ever since.
And I love how you two are a living example. I'm watching the two of you work together. Is this not beautiful?
So sweet, right?
A father and daughter cutting
really
up
nice.
fresh vegetables together. And I'm just watching this, and I can envision this taking place while you're at home and how exciting it is. But the best part is when it's all said and done, you get this delicious
meal.
dish that is not only healthy, but hearty.
Right.
And it's loaded with fiber, protein, nutrients.
Yeah, the fresh bell peppers add so much color, antioxidants, just healthy and delicious. So tell us about this next one. This looks really interesting too.
We're moving on to our dinner. In this case, we do a turkey meatball, which is, turkey tends to be very lean. And in this case, it's about a 93% and then 7% fat. In lieu of the breadcrumbs and butter, we added, we use roasted cauliflower and an egg. And so that actually binds the turkey together. So we sear them, brown them on the outside, and then toss them in the oven.
Difficult to sit there for 45 minutes waiting, smelling the turkey meatballs in my room, trying to do homework. It's really hard to focus.
I can imagine, because these are really delicious.
These are
They're
quite good.
outstanding.
And that substitution, spot on. This is really tasty. Have to ask you, Kai, what's your favorite go-to meal?
Honestly, I really like the rack of lamb. It takes a while, but it's really good and worth it in the end to go through all the time to cook it.
And if something takes a while, will you get it started and then go do some homework and come back?
Mainly, yes.
Mainly?
Mainly, yeah.
Well, and I think you two highlight something else that's wonderful is by being a team, you might be able to go do a little bit of homework. Dad, you step in, right? It's true teamwork. Living, breathing example of how it works when you cook with your kids. Every single one of these dishes, phenomenal.
Fantastic.
Thank you for
Well
sharing
done,
these with
guys.
us. Really appreciate it.
Excellent.
We'll be right back. Coming up, you get a pillow like this, put this side up, and you may end up with... That's coming up.
Following program contains mature subject matter. Viewer discretion is advised.
This next product gives new meaning to the phrase pillow talk. They have phrases on them such as, yes,
Yes,
or not tonight, I have a headache.
We like this one a lot.
We like this one.
I found the yes.
This is so playful and so
You guys
cute.
like it?
I love it.
I love it.
Yeah, I love it.
It's nonverbal communication.
It is.
Of course, with these pillows, you'd have to be a little bit careful. You come home from work, you're exhausted, you're not paying attention. You put it down like this, you fall asleep, and your spouse comes home. Next thing you wake up, they're naked, ready to go, and you're like, oh no, yes, no, oh,
Well,
honey,
I changed my mind.
not tonight, I have
Well, they
But
say
communication's so important.
Communication is so key. According to the Journal of Sex Research, couples who communicate have much better sex lives. So this, I think, is a really cute, nonverbal way, set the mood.
The way I communicate is I actually just roll into the bedroom, and if I'm ready to go, I put my football helmet on. I'm like, come on, honey.
Yeah.
That's a really weird image, Travis.
That's like redneck foreplay. Brace yourself, Bridget.
Well, here's the deal. You can get a pillow like this. You can put this side up, and you may end up with some afternoon delight.
Yeah. Delight, that's our word of the day. So head on over to thedoctorstv.com and enter DELIGHT for your chance to win a bundle of kitchen products from Ipare valued at $200.
And we want you to all go home and cook. You're going home with it.
Does anybody really like doing laundry? Couple
said
people.
yes.
I applaud you. You love it. That's great. But what if you could make your home smell fresh and save on the amount of dryer sheets you need to use when you're doing your laundry. Thanks to a recent viral cleaning hack from Instagram user Mrs. D's Cleaning Reviews, you could do this with the help of a simple sponge. All you have to do is pour some fabric softener into a container, add water, and submerge your sponge. Then remove the sponge, squeeze it without wringing it out completely, then pop it into your dryer. As the dryer heats up, it'll fill your home with a fresh, clean scent. And since you can reuse the sponge, it eliminates the need to keep buying dryer sheets.
So don't wash your clothes with it. It's in the drying phase.
So who does laundry in your household, Drew?
Neither one of us. No. Occasionally you do a load. And when I'm in the desert, I do my own laundry. So it's all good. I'll try this.
I want to do a little home video of you doing the laundry.
Anytime, come on down.
Hey, if you missed anything on today's show, visit us at thedoctorstv.com. So long.